Have you ever watched a master craftsman at work? Or maybe a high-level chess player? There's this distinct moment where you realize they aren't just reacting.
No, not at all.
They're operating on a completely different timeline. They're seeing 10 steps ahead, building this complex model of the future in their head before they even, touch a piece.
Exactly. It's the difference between just seeing the pieces on the board and seeing the geometry of the game.
And today, we are applying that specific lens to one of the most high-stakes environments imaginable.
Head and neck surgery.
We've got a stack of really fascinating material today that focuses on what is called the FRCS level of clinical reasoning.
Right. And just to orient everyone, FRCS stands for the Fellowship of the Royal Colleges of Surgeons. So in the UK and other systems, this is the exit exam. It's the gold standard that takes a doctor from being a senior trainee to being a consultant.
But the mission of this deep dive isn't just to help someone pass an exam. It's not even really just about oral cancer, though that is the case study we're using. It's about understanding a massive shift in mental processing. We're looking at the shift from just gathering information
To staging the disease in your head. That is the key phrase, staging in your head.
And what does that actually mean?
Well, the difference between a rookie and an expert is that the rookie collects facts like they're filling out a grocery list. But the expert is constantly synthesizing those facts into a sort of 3D model of the disease before they even pick up a scalpel.
So to do this, we are going to walk through a synthesis guide for these surgical exams. And then we're going to apply it to a specific case study of a theoretical patient named Mr. X.
Right.
The goal is that by the end of this, you, the listener, will be able to hear a single symptom and immediately spot the difference between a rookie question and a consultant level question.
And honestly, once you see this distinction, it's kind of hard to unsee. It changes how you view competence in almost any field, not just medicine.
Okay, let's start with the source material's first big concept, the mindset shift. It contrasts the checklist approach with the staging approach. And I think most of us have experienced the checklist approach.
Oh, absolutely. The checklist approach is, typical of medical students or early trainees. They have this mental list of questions, and their goal is just to fill in the blanks.
Where is the pain? How long have you had it?
Exactly. They write down the answers, but they aren't necessarily processing what those answers mean for the anatomy in real time. It's data gathering, not data processing.
So the consultant, the expert, is doing something totally different.
Completely different. The consultant is hunting for the T stage.
T stage being tumor stage.
Correct. They are looking for size, site, and invasiveness. They aren't asking questions to be polite. They're asking questions to map the geography of the cancer.
Let's make this concrete. Pain. The mnemonic in the notes is palliate, but let's focus on one specific thing. The source says the common way to ask is just, does it hurt?
Right. And does it hurt? It's a subjective question. It tells you the patient is uncomfortable, but it tells you almost nothing about the cancer's behavior.
So what's the consultant level question?
It's highly specific. Do you have refertotalgia?
Meaning pain in your ear.
Yes. Do you have pain in your ear?
Okay, pause there. We are talking about mouth cancer. A tongue ulcer. Why on earth is the surgeon asking about the ear? That feels completely random.
That's the aha moment. It comes down to neuroanatomy. The ear and the back of the throat, they share nerve pathways.
Oh, right.
Specifically, cranial nerves 9 and 10, the glossopharyngeal and vagus nerves. The brain basically gets its wires crossed. It perceives pain from the base of the tongue as coming from the ear.
So if a patient with a tongue ulcer says, yeah, my ear is killing me, it's not an ear infection.
Almost certainly not. It signals that the cancer has infiltrated deep enough to involve those specific nerves. It's a proxy for depth. If the cancer is just on the surface, you usually don't get that ear pain.
So ear pain actually equals advanced disease.
Precisely. It signals a higher T stage. You've just diagnosed the likely depth of the tumor without even looking in the patient's mouth yet. That is the efficiency we're talking about.
Wow, that's like a cheat code if you know the wiring.
Yeah.
Okay, let's look at the lesion itself. The mnemonic here is SPOTA. The rookie asks, is the sore big?
Which is vague. Big is relative. The consultant asks, is there induration and is there fixation?
Induration. That term pops up a lot. Can we define that clearly? What are we actually feeling for?
Induration just means hardness, but not just firm. We're talking rock hard. The source actually calls induration the pathognomonic clinical sign of malignancy.
Pathognomonic meaning.
Meaning if you feel it, it's almost certainly cancer. If you just bit your cheek, that ulcer will be soft. Inflamed, sure, but pliable. If it's cancer, the cells are so densely packed and disorganized it feels like wood or stone.
And fixation.
Fixation is asking, is it stuck? Is the tumor glued to the jawbone or the deep muscle underneath?
Because if it's stuck,
If it's fixed, I might not be able to cut it out. Or the surgery just became twice as complex. So fixation dictates resectability, you see. Every question determines the next surgical move. The rookie is asking, what is it? The expert is asking, can I remove it?
there's another detail here about bleeding and odor that I found pretty grim. The source contrasts, does it bleed, with, is there spontaneous bleeding? Why that distinction?
It's a subtle but critical one. Look, any sore will bleed if you poke it, that's mechanical trauma. But spontaneous bleeding that happens while you're just sitting there suggests the tumor tissue is friable.
Friable meaning fragile.
Yes, crumbling. It means the cancer is growing so fast it's outstripping its own blood supply and structural support. It's literally falling apart. And the odor, the text calls it fetor oris, that suggests necrotic tissue is rotting inside the mouth.
It paints a very aggressive picture.
It does. It tells the surgeon, this is fast moving. We don't have months, we have weeks.
So we've looked at the surface clues. Now let's go deeper. The next section covers functional impact, looking for red flags of invasion into muscles and bones.
This is what we call local invasion. You're trying to figure out what structures the cancer has, eaten into. And the classic sign here is trismus.
Lockjaw.
Yes. Now, the common way to check is just asking, can you open your mouth? But that's too vague. The expert measures the interincisal distance.
And the source says you measure it in fingers.
It's a quick bedside metric. Can you get 3 fingers in between your incisors? 2. Only 1. If that distance is decreasing, it's not just stiffness. It usually means the cancer has invaded the pterygoid muscles.
The pterygoids are those deep jaw muscles for chewing.
Correct. The medial pterygoid acts like a sling for the jaw. If the cancer invades that muscle, it tethers it so it can't stretch.
And if the cancer is in the pterygoids.
It means the tumor is deep. It immediately changes the staging to T4. It's no longer just on the tongue. It's digging into the machinery of the jaw. And that's a much harder surgery.
Speaking of machinery, what about the tongue itself? The source mentions tethering.
Right, so you ask the patient to stick their tongue straight out. If the tongue pulls to one side, or if it can barely clear the lips, that's tethering. It means the tumor has infiltrated the intrinsic muscles of the tongue. It's like an anchor.
And that leads to difficulty speaking. Dysarthria.
Exactly. Function follows anatomy. If the function is broken, the anatomy is compromised. The patient's inability to move their tongue tells you the depth of invasion just as well as an MRI might.
Now there's one warning sign here that actually scared me a bit. Loose teeth. But isn't that common?
That's the trap. If an adult has loose teeth with severe gum disease, okay, periodontal issues, but if they have a loose tooth without obvious gum disease, that is a massive red flag.
Why?
It implies the cancer has eaten into the alveolar bone,
Yeah.
the jawbone itself. The tooth is loose because its socket is being destroyed by the tumor.
So the foundation is crumbling.
Correct. If you see that, you are immediately staging for bone invasion. You're effectively planning a partial mandibulectomy, cutting out part of the jaw just by wiggling a tooth.
Wow. Okay, so that brings us to risk stratification. The N and M staging nodes and metastasis.
This is the general view. We step back from the mouth and look at the whole patient.
And the first metric is weight loss. The source is very clear. Are you losing weight? Is not a good enough question.
No, it's totally unreliable. Everyone says maybe a little. You have to quantify it. Kilograms over a specific time frame. The guide notes that more than 10% body weight loss in 6 months indicates cachexia.
And cachexia is different from just starvation.
Oh, very different. Starvation is just lack of calories. Cachexia is a metabolic state where the body starts consuming itself because of the cancer. It's often a marker for M-stage metastasis. It suggests the cancer has spread and is sucking the energy out of the whole system.
Now habits. The source lists smoking and drinking, but it's very granular. It mentions pack years and something called Gutka.
Pack years is a way to calculate total exposure. 1 pack a day for 20 years is 20 pack years. It quantifies the cumulative damage. But Gutka is a specific preparation of betel nut and tobacco common in South Asia.
And it's not smoked.
No, it's chewed. And crucially, it's often kept in the cheek, the buccal sulcus, for hours, maybe 10 hours a day.
So it's just marinating the lining of the mouth in carcinogens.
Exactly. It creates a field change. The entire lining of the mouth becomes unstable, so even if you cut out the tumor, the remaining tissue is likely precancerous. The whole field is condemned.
The source also mentions a history of oral sex.
Right, and that's relevant for HPV-related oropharyngeal cancer, so tonsil and base of tongue cancer. It's a completely different beast than the smoking-related cancers. The pathology, the prognosis, the treatment response, it's all different.
So the history tells you the pathology before the biopsy does.
In many cases, yes.
Before we move on, there's one more specific sign here I found really compelling. It's called Vincent's sign.
Ah, yes, the Sherlock Holmes clue. Vincent's sign is unexplained numbness of the lip or chin.
Why is a numb chin such a big deal?
It's a huge deal. The mental nerve runs through a canal inside the lower jaw and supplies sensation to the chin. If the chin is numb, it means the cancer hasn't just touched the bone, it has invaded the inferior alveolar nerve inside the bone. It's called perineural invasion.
The cancer is traveling along the nerve.
Yes, it's using the nerve sheath as a highway to spread, maybe all the way back to the skull base. If you see Vincent's sign, you aren't just dealing with a lump, you're dealing with a tumor that's attacking the nervous system.
That is terrifying. But incredible that a simple question, is your chin numb, reveals so much.
It changes the entire surgical plan.
Okay, let's put all this into practice. We have our case study to test our consultant mindset. Let's meet Mr. X.
Mr. X, our theoretical patient, he's a 55-year-old male.
And his profile fits the risk factors perfectly. He's a 30-pack year smoker and a chronic Gutka user.
So immediately, your alarm bells are ringing. This is very high risk. 30 pack years puts him in the danger zone for lung issues as well as oral cancer.
He comes in with a non-healing ulcer on the right side of his tongue. Been there for 6 weeks. So using the consultant mindset, what are we looking for?
Well, let's look at the pain. The case says he reports referred otalgia, right ear pain.
Boom. We know what that means now. Deep nerve involvement.
Correct. He also has odonophagia pain on swallowing, which suggests the tumor might be extending towards the back of the tongue.
What about the functional assessment?
He has trismus. The source says it's restricted to a 2-finger breadth.
So he can only open his mouth about 2 fingers wide. That implies the pterygoid muscles are involved.
Exactly. He's losing function. However, and this is important, he does not have Vincent's sign,
No numbness in the chin.
which is a very good positive finding. It suggests the nerve inside the jawbone might still be intact. It's a small mercy, but it might mean we can save the continuity of his jaw.
And when we do a physical exam,
The ulcer is 3 centimeters. It is indurated, rock hard, and it is fixed to the underlying musculature.
and there's a lump in his neck, right level 2.
And that's our end stage. The cancer has jumped to the lymph nodes.
So we have a clear picture. This is not just a sore tongue. It's a deep, invasive, hard tumor that's spread to the neck. Now comes the master plan. How do we treat Mr. X?
Right. Step 1 is diagnosis, and the source is emphatic here. You perform an incisional biopsy, not an FNAC.
Why not? FNAC fine needle aspiration seems so much easier. You just poke it with a needle.
Because FNAC just sucks out loose cells. It tells you, yes, there are cancer cells, but that's not enough for the primary tumor. An incisional biopsy takes a wedge of tissue. You need to see the architecture.
You need to see if the cells are breaching the basement membrane.
Precisely. That barrier is the definition of invasive carcinoma. You need the map, not just a soil sample.
Got it. Okay, step 2, staging with imaging.
We need an MRI of the head and neck to measure the depth of invasion, and we absolutely need a CT of the chest.
To check for lung metastasis.
Yes, but also to rule out a second primary. Remember those 30-pack years? It is terrifyingly common to find a separate lung cancer growing at the same time.
That makes sense.
Oh.
Okay, assuming the chest is clear. Step 3, the surgery.
For Mr. X, it's a big operation. First, a wide local excision with a 1 centimeter margin. We call that the safety margin.
And the neck.
Because of that lump, he needs a modified radical neck dissection. We're clearing out all the lymph nodes in that area.
And finally, reconstruction. You can't just leave a hole in his tongue.
No, you can't. If you did, he wouldn't be able to speak or swallow. The source specifies a microvascular free flap, specifically a radial forearm free flap.
Wait, they take tissue from the arm?
Yes, they take a patch of skin, fat, and the radial artery and vein from the forearm. They completely detach it, move it to the mouth, and sew it in to patch the hole.
How does it stay alive?
That's the microvascular part. Under a microscope, they stitch the tiny artery from the arm to an artery in the neck. They replumb the blood supply.
That is incredible engineering.
It is. It's an 8 to 12 hour surgery, and it's all or nothing. If that tiny artery clots, the whole flap dies. The stakes are incredibly high.
So after surgery is step 4, adjuvant therapy.
Yes, we wait for the pathology report. We're looking for high-risk features. Did we get clear margins? Is there extracapsular spread? Perineural invasion?
And if those are present,
Then surgery isn't enough. He will need radiation and possibly chemotherapy to mop up whatever microscopic disease is left.
so bringing it all back to how a consultant presents this. The source gives a script. It's not a rambling story.
No. Listen to the difference. A student might say, Mr. X is a 55-year-old guy, he smokes, and he has a sore tongue that hurts his ear.
True, but low resolution.
Exactly. A consultant says, this is a case of stage 3 squamous cell carcinoma of the oral tongue. My priority is an R0 resection neck dissection resection and microvascular reconstruction.
R0 resection, meaning cutting it all out with clean margins.
Exactly. It conveys authority, competence, and a plan of action in 2 sentences. It tells everyone, I know what this is, and I know how to fix it.
It's impressive. What stands out to me is that the consultant isn't just smarter, they're more organized. They have a framework that filters out the noise.
That's the professional authenticity the source talks about. The difference isn't always raw intelligence. It's the ability to synthesize isolated facts into a cohesive narrative.
A 3D mental model.
Yes. When you ask questions like, is your chin numb? Or does your ear hurt? You aren't just gathering data. You are testing your hypothesis. You're proving that you understand the disease better than the disease understands itself.
And that gives you the confidence to act when the stakes are literally life and death.
Exactly.
So here's a provocative thought for you to carry with you today. We've been talking about surgery, but this applies to almost anything: engineering, law, business strategy. Think about the way you ask questions in your own field.
Are you asking checklist questions just to fill silence? Or are you asking staging questions, questions that reveal you understand the deep structure of the problem?
Professional authenticity isn't just about what you know. It's about how you investigate what you don't know. The quality of your question really does determine the quality of your answer.
Couldn't have said it better.
That's it for this deep dive. Thanks for listening.